I think we can start. Thank you all for joining us for this webinar. This webinar is sponsored by Response Biomedical. I am Eben Thomas, Director of Customer Success with Response Biomedical, and we are coming to you live from Vancouver, Canada. Mostly I am. The doctors or the speakers who are joining us are coming from different countries as well. Response Biomedical manufactures and develops RAM technology, which is used in acute care setting. We are a 30-year-old company, and this is our 30th anniversary. The topic for this webinar is examining clinical benefits of Troponin I in adult and pediatric patients. The topic will be presented to us by Dr. Lizeth Castelblanco, pediatrician from El Rosario University, and Dr. Andres Florez, resident internal medicine, Pontifical Hawaiian University. This webinar will be for 50 minutes, and then we will possibly have a Q&A session. I thank you all for joining us for this webinar, and I hand it over to Dr. Lizeth Castelblanco. Thank you so much.
Thank you, Eben. So we're going to start with the first clinical case. It's a 78-year-old male patient with a history of diabetes and hypertension. He arrives to the emergency department with an oppressive chest pain associated with dyspnea that began just 3 hours ago. The initial EKG didn't have important changes, but he had an initial troponin of 1,000 with an ULN of 25. What would your initial diagnosis be? You are correct, myocardial infarction. The second clinical case we want to bring up is a previously healthy 11-year-old male patient with a history of 2 weeks of fever and diarrhea. He arrives to the emergency department with an oppressive chest pain associated with dyspnea that began just 24 hours ago. The initial EKG showed sinus tachycardia, but with an initial troponin of 100 nanograms per milliliter with an URL of 16 nanograms per milliliter. What would your main diagnosis be? You are correct, acute myocarditis. So the only cause of troponin I elevation is not acute myocardial infarction.
Well, this is really important, as Lizeth has been saying to you, because as he told you that the only elevation of troponin is the only cause of elevation of troponin is not myocardial infarction. There are a lot of other causes that are related to myocardial injury that can lead to an elevated value of troponin. And there are even causes that are not related to myocardial injury that can cause an elevation of troponin. In this graphic, we have some examples such as anemia, hypoxemia, hypotension, ventricular tachyarrhythmias, and others. But it is obvious when we're talking about the clinical use of troponin in adult patients that we have to talk about chest pain, because chest pain is the main clinical complaint that adult patients have when they arrive to the emergency department. And it varies depending on the age of the patient, how probable it would be that acute myocardial infarction is the cause of the chest pain in that specific patient. As you can see in this chart, from 65 years and forward, we have to obviously take more into account the probability of acute myocardial infarction. But in younger people, there are a lot of other causes that can be the clinical complaint or the cause of the chest pain of the patient, and it's not related to myocardial infarction, and some of them can even elevate troponin. That is why we have some clinical guidelines, such as this one of 2021, of the evaluation of diagnosis of chest pain. And in this guideline, it is really important for us to know that the troponin has a key role in the evaluation of diagnosis of this clinical complaint. When you have a patient that arrives to the emergency department with an acute chest pain, you need to perform a good history, a good physical examination, and an electrocardiogram. With these elements, you need to classify the patient in 3 different groups. The first group would be the patient that has a chest pain of an obvious non-cardiac cause. The second group would be an obvious non-ischemic cardiac cause. And the third group would be the possible cardiac ischemic cause or a possible acute coronary syndrome. When you face this specific group of patients, you need to take a troponin, and with the troponin, you need to implement a clinical decision pathway in order to determine whether or not a patient has an acute coronary syndrome and specifically an acute myocardial infarction. So, as you can see, troponin is a key element in the diagnosis of these patients. So, as we're talking about the possibility or the diagnosis of acute myocardial infarction, we need to know what we understand with the words myocardial infarction. It exists the fourth universal definition of myocardial infarction that was published by the European Society of Cardiology in 2018. They established that in order to diagnose acute myocardial infarction, you need two key elements to be present in the patient. The first element is the evidence of ischemia. And that evidence of ischemia can be evidenced by the clinical presentation, by radiological criteria. But the second element, that is the important one for this topic in specific, is that you need the presence of acute myocardial injury. And you can only determine that a patient has acute myocardial injury by detecting abnormal cardiac biomarkers. Because what happens when you have a myocardial injury? When you have a myocardial injury, the cardiomyocytes start to release their intracellular components in the blood. And those components could be enzymes, could be proteins. And if you measure them in blood and they are elevated, they can show you that the patient has an injury to the cardiomyocytes. There are a lot of clinical biomarkers or cardiac biomarkers that have been developed and used, but we know that troponin is the best one, and specifically troponin I is the best one that we could use. The reason of this is that troponin I is specifically and uniquely produced in cardiomyocytes, while troponin T and other cardiac biomarkers are also produced in other tissues in the body. And if you have a injury in those other tissues, you would find elevated values of these biomarkers in blood, and this would not be related to a myocardial injury. So, as we know that troponin is the cardiac biomarker that we need to use, it is important for us to know how does the troponin behave in time when you have a myocardial injury. And you can have like two different scenarios in this specific case. You can have a chronic myocardial injury or an acute myocardial injury, that is the one that would be important for the diagnosis of acute myocardial infarction. So what happens? With troponin, we have like a value of normality above which we understand the value of troponin as abnormal. And that value of normality is the 99th percentile. When you find a value of troponin that is elevated or above the 99th percentile, you will say that the patient has an myocardial injury. How would you differentiate if it is chronic or acute between or the element that would make this difference is the stability of the value over time. In chronic myocardial injury, you have an elevated troponin, but it is stable over time. While in acute myocardial injury, you have a patient that will start to elevate progressively troponin, and afterwards it will start to like downward that value. And that is important because the main difference would be this. When you take one value of troponin that is altered and a second value of troponin that is also altered, but you have a significant change between these two values, you will be talking about an acute myocardial injury. This is like the first key element that we need to understand from this graphic. And the second element that is very important is that, as you can see, when you have an acute myocardial injury, you need certain amount of time in order to allow the troponin to get elevated, the sufficient amount that you need in blood in order for it to be above the 99th percentile. And this is important when we start to talk about the clinical specific use of troponin when you are suspecting acute myocardial infarction as a diagnosis in the patient. So it is really important that we have like this key message from this first part, and is that in order to diagnose acute myocardial infarction, you need to identify acute myocardial injury. The only like clinical scenario in which this would not be necessary is when you have an acute myocardial infarction with ST elevation. Because if you have one unique value of altered troponin above the 99th percentile and a patient that has an elevation of this ST segment in the clinical context of acute myocardial infarction, you could do the diagnosis without performing a second value of troponin. But if you don't have that ST segment elevation, it is mandatory for you to make the second test of troponin and see whether or not you have that significant change to differentiate between chronic and acute myocardial injury. So, as we have been talking, it is important for us to know how to interpret troponin. But in order to do that, you need to understand or to know what are the types of assay that we have in order to measure troponin in the blood of our patients. We have like two big groups of assays: the sensitive troponin assays and the high sensitive troponin assays. The sensitive troponin assays were the first assays that allowed us to determine a quantitative value of troponin. And when you compare sensitive to high sensitive assays have a lower sensitivity with a higher specificity. But the high sensitive assays, the two key elements that make them different from the sensitive assays are the two that you are seeing in your screen. The first one is that the exam allows you to identify or to detect troponin in more than 50% of patients that are below the 99th percentile. What this means is that you identify a quantitative value of troponin, but that value is not above the 99th percentile, and this happens in 50 or 100 of healthy patients that you measure this assay. And the second key component is that you need a coefficient of variation that is of less than 10% at the 99th percentile. What does this gives you in terms of advantage between high sensitive and sensitive troponin assays? That with high sensitive troponin assays, you will have a quicker diagnosis, a quicker implementation of clinical decision pathways, and this would allow you to start in a quicker way the management or the specific management of acute myocardial infarction. When we talk specifically about sensitive troponin assays, it is clearly established that troponin I outperforms troponin T. This would be most likely because of what I told you earlier, that troponin I is specific or is unique to cardiomyocytes, while troponin T can also be produced in other tissues. But it has also been well established that when you use high sensitive troponin, it has a better performance than sensitive troponin, but specifically in one item. And this item would be like the quicker diagnosis. As you can see in your screen, when you have less than 2 hours since the onset of symptoms in a patient that has an acute myocardial infarction, at that time you can have a positive value of high sensitive troponin, while a sensitive troponin would still be negative. So this is important because it allows you a quicker diagnosis, and as we would see in the following slides, it allows you to implement some clinical decisions pathways that allows you in even 1 hour to determine whether or not a patient has an acute myocardial infarction. Even if you use sensitive or high sensitive troponin assays, there are some considerations that you need to take into account when you are using these laboratories. First of all, each assay has its own 99th percentile. And this is really important because we don't have a unique or a universal 99th percentile that applies to all of the assays of troponins, but each clinical assay has its own 99th percentile. So when we are talking that we need two values of troponin to see a significant change to diagnose an acute myocardial injury, you need to understand that these two clinical values or these two clinical assays have to be the same assay. You cannot use first, I don't know, one type of sensitive troponin and second, one high sensitive troponin and compare them because they are not comparable. You need to use the same clinical assay. Second consideration, there are many variations not related to myocardial injury that can alter the value of troponin in blood of the patients. The first of all, and really important, is sex. It is really important troponin between male and female patients. And such important is that we have known now by the IFCC that we need to have a unique 99th percentile, not only for each clinical laboratory assay, but also for that assay, you need a different 99th percentile for female and male patients. Other like variables that can affect the value of troponin are altered kidney function, age, and even the time of the day. So I have been telling you a lot about this acute injury, this significant change, but how do you implement that in clinical practice? What is the amount of difference that you need in order to diagnose an acute myocardial injury and further an acute myocardial infarction? This also varies according to the assay, but the fourth universal definition of myocardial infarction did some statements that are the ones that we are currently using in clinical practice. When you use a high sensitive troponin assay, you need a change of at least 20% between the first and the second value in order to determine an acute myocardial injury. When you use a sensitive clinical troponin assay and the first value was below the 99th percentile, you need a change of at least 20%. But if you are using a sensitive troponin assay and the first value is above the 99th percentile, you need a change of 50 to 60%. And this is really important because when you read guidelines, all people have in mind only about the value of 20%. But if you are not using high sensitive troponin and you are using a sensitive troponin assay and the first value was positive, you do not need 20% of change. You need at least 50 to 60% of change. And this would make a really important difference in order of diagnosing or not an acute myocardial infarction in a patient. So all of this that I have been telling you is applied to the diagnosis of acute myocardial injury in clinical practice. And it is evidenced here in the 2020 guidelines of the European Society of Cardiology for the diagnosis and management of acute coronary syndromes in patients without ST elevations. And in this guideline, they establish really clear that if you have the possibility, you should use a high sensitive troponin assay. But this not means that it is the only clinical assay that you could use. If you don't have high sensitive troponin assays, you could use sensitive troponin assays. Why do they recommend better the high sensitive troponin assays? First of all, because it has a higher negative predictive value, but the main importance or the main reason of doing this is this algorithm that you are seeing in this slide. How does this work? When you have a patient with a suspicion of an acute coronary syndrome without ST segment elevation, you should perform a first value or first assay of troponin. You can have like two extreme scenarios. The first scenario is that you have a really, really low value of troponin, even indetectable troponin, in a patient that has at least more than 2 to 5 hours since the start of the onset of symptoms. If you face this scenario, you can rule out the diagnosis of myocardial infarction. The other extreme value is when you have a patient that has a clinical picture that is highly suggestive of acute myocardial infarction, and you have a really high value in the first troponin assay. According or whether where you read, you need at least 5 or 10 times higher than 99th percentile to classify as that extreme value. When you have that scenario, you don't need to perform a second troponin assay. You can rule in the diagnosis of acute myocardial infarction, even though you don't have the ST segment elevation in the electrocardiogram. But these two clinical scenarios are not the one that you are usually going to face in the emergency department. You are usually going to face a patient that has a low or a high value or a normal value, but you don't have 10 hours of presentation or an extreme elevation of troponin. When you face this really more common scenario, you need to perform the second value of troponin. If you have a high sensitive troponin, that second value should be measured 1 hour separated from the first one. And in that, you would check if you have or not the significant change in order to say that you have an acute myocardial injury and so an acute myocardial infarction. But what happens when you don't have a high sensitive troponin assay? The main problem of this guideline is that it does not establish how to use the sensitive troponin assays in an algorithm like this one. But from other sources, you can know that you need at least 3 hours of separation between the first and the second assay when you are using sensitive troponin. There are a lot of criticism that has been made to this guideline, not only for this that I have just told you of that they know that they do not specify how to use sensitive assay, but they are like really focused only on high sensitive troponin assays, and they like forgot that a lot of people are not going to have access to that clinical or to that specific assay. The other like criticism that has been made by the IFCC, that is like the maximum authority in order of cardiac biomarkers, is that they don't establish a different cutoff point of the 99th percentile for male and female patients. And there are a lot of other critics, but the message is that the guidelines are not perfect. And you need not only to know how to interpret high sensitive troponin, but you also need to know how to use and interpret sensitive troponin assays. And even more when you see that the troponin is not the only element that you need in order to diagnose acute myocardial infarction, because as I told you, the definition had the acute myocardial injury component but had the other component that is the evidence of ischemia. So you need to implement a clinical decision pathway in order to make an adequate evaluation and diagnosis of this specific pathology. This graphic is really impressive, at least for me, when I was like performing this webinar, or when I was like doing the presentation for this webinar, because if you see in North America and in South America, we use in less than 50% of the hospitals or the clinical practice centers high sensitive troponin assays. In more than 50% of the cases, we are using sensitive troponin assays. So, as I told you earlier, and I repeat you now, it is important for you to know how to use and interpret the sensitive troponin assays. But we have another scenario. There are people in rural areas, pre-hospital care, that do not have access, not even to the high or the sensitive troponin assays. In those scenarios, it has been like really important, or people are really focusing in the last years in the point of care testing, or what we know as POCT. There are a lot of like benefits or theoretic benefits of using POCT, because it results in like a quicker diagnosis, a quicker implementation of management specifically directed to acute myocardial injury. Or, for example, in rural areas, it can also prevent you to taking a patient to a more specialized center just for the issue of performing a laboratory assay of troponin. If you have a POCT that is negative, it would allow you to rule out the patient, discharge the patient without having to transfer it to another center of more complexity. Does this have like evidence? Does this have like support from the literature? And the answer is yeah. We can see that there are a lot of clinical trials that have been performed comparing POCT to even high sensitive troponin assays of the laboratory, and we have seen that there is a really good correlation between the values of POCT and high sensitive troponin assays. And as I told you, it has been implemented, like for example, in this pilot study from the BMJ, specifically in rural areas. In this study, that it is important to mention that it is a pilot study with a really limited number of patients, 180 patients, as you can see in the chart. They used a POCT in a clinical decision pathway, and they rule out and discharge patients that had POCT negative values of troponin. And it worked really, really well. It has been also shown that it has like other possible benefits, like reduction the length of stay in hospitals in patients with POCT that are negative, starting like earlier the treatment of acute myocardial infarction, and other benefits that have been proven. But it is important for me to tell you that these benefits have been proven in small clinical trials like the one that I showed you earlier. And that is the reason that we don't see or reflect these clinical trials in proper recommendations in clinical practice guidelines. Earlier, like the most like recent news that we have from POCT is this study that they developed a POCT that like has the characteristics of a high sensitive troponin assay. The coefficient of variation, identifying the 50% of patients with positive values but not above the 99th percentile, and they used this POCT in the algorithm that I showed you from the clinical practice guideline of the European Society of Cardiology. And once again, it performed really well. So it is really possible that in the next or in the following years, we're going to see more recommendation in guidelines regarding the use of POCT. Even though in the past year, the IFCC published an article related specifically to the interpretation of POCT, and they gave a message that I think that is really important. If you don't have high sensitive troponin assays, if you don't have sensitive troponin assay, but you have a POCT, you should use the POCT and measure the significant change with the POCT in order to diagnose or not an acute myocardial infarction in your patients in your clinical practice. So this is what I have to tell you related to the use of troponin in adults, specifically in acute myocardial infarction. But as we have talked and we have mentioned earlier, there are a lot of other causes of elevation of troponin, and specifically in pediatric populations, the clinical scenario is really different. So I will leave you with Lizeth in order for her to tell you all of these other scenarios.
Thank you, Andres. Okay, so let's remember a little bit about physiology. Andres mentioned a little bit about where troponin I comes in. Troponin I, I'm going to refer to troponin I as TNI. It's a structural protein found in cardiac muscle, and it's released during myocardial injury. That's a really broad spectrum of entities. So during ischemia, during trauma, during myocarditis, etc. In this picture, we can see the difference between the cardiac TNI, the fast skeletal, and the slow skeletal. Why is it different? Because the N-terminal region is where the cardiac TNI is structurally different. Why is that important? Because we don't have elevations of TNI related to blunt trauma in my leg, right? That's really interesting also because the embryonic heart has a different structure. It doesn't have the N-terminal region in that location, but it has the structure of the slow skeletal one. And that is really interesting as well because the cutoff values for neonates and infants are different than bigger children just because of that structural change in the TNI. How many types of TNI exist? Well, the slow skeletal, fast skeletal, and in the cardiac TNI, we have three, the TNC, TNT, and the TNI. We can see here a diagram of the cardiac sarcomere. So muscles are made of muscle fibers. Muscle fibers are called cardiomyocytes. So each cardiomyocyte is made of myofibrils, which are over here. They are linked, serially linked sarcomeres, and they are divided by these that are the Z lines. We have in each sarcomere the myosin, which is over here, the thick filament, and the actin, which is the thin filament. We're going to refer to the actin band as the I band, and the part where the actin and the myosin are together as the A band. We see over here the M line, that's the part where only the myosin is located. So we have the sarcoplasmic reticulum. Remember, the sarcoplasmic reticulum is that place of the cell where the calcium is located. We have these, which are the terminal cisterns. We have these that are the terminal tubules. We have this little structure, which is the dihydropyridine receptor and the ryanodine receptor. So all these weird names just related to how the muscle contraction takes place. So inside the sarcoplasmic reticulum is the calcium. So the calcium is going to exit the sarcoplasmic reticulum through the TCs, the terminal cisterns, and that's gonna enable the calcium to exit over here and enable the muscle contraction by sliding over the myosin over the actin. So this sarcomere starts to shorten due to the calcium, and that's why we have muscle contraction. Myosin over here has 2 heavy chains and 4 light chains. The heavy chains are going to coil around each other. They're going to form a double helix, and they have 4 parts: the tail, the body, 2 arms, and 2 heads. The arms and the heads are going to be the ones that make the cross bridges that are going to grab the actin, and they're going to draw it closer to the midline. And again, that's where muscle contraction takes place because of the calcium ion. Actin over here is also composed of 2 chains. The chains have little binding sites. They're called myosin binding sites. But if the myosin binding sites are just exposed, we would have a muscle contraction that would be perpetuated forever. But those actin or myosin binding sites, are covered, and they only are uncovered when muscle contraction needs to take place. So, what does troponin do? Why is troponin so important in all of this physiology? Troponin is the protein that regulates the availability of myosin binding sites, so those little sites that I mentioned, so that they are open only in the presence of muscle contraction, again, signaled through the calcium ion. And that's going to prompt the myosin head to bind to them. So cardiac TNs, cardiac troponins, I mentioned there are 3. We have the troponin T, the troponin C, and the troponin I. Troponin C is the one that's going to attach to calcium, and that's going to trigger the structural change I mentioned in the complex. Troponin T over here is going to inhibit, it's going to bind the whole complex to tropomyosin. The tropomyosin is going to be the one that's going to cover those myosin binding sites. And the troponin I is going to inhibit actin and myosin interactions. It's really interesting to remember some physiology about troponin I. Okay, so acute myocarditis. Acute myocarditis is an inflammatory disease of the myocardium. It can be acute, but we also have chronic myocarditis. We have very different etiologies of acute myocarditis, but the viral one in children is the most predominant one. We have a really broad clinical spectrum, as broad as I have a chest complaint. The kid has a little chest complaint. He may be just with tachycardia, or another kid may present with acute cardiogenic shock. It's really broad. We have an annual incidence of about 0.8 to 2.13 children per 100,000 patients, and the males are mostly affected. We have 2 peaks of presentation during infancy and adolescence. So you would ask yourself, why are we talking about acute myocarditis and troponin I? And Andres just talked about acute myocardial infarction. Because troponin I, as we are going to see in this webinar, it does pose a really, really important place in the diagnosis of common pathologies or severe pathologies that if they were undiagnosed, well, we would have serious complications with our patients. So relating the pathophysiology to acute myocarditis, we do have 3 phases. We do have these phases studied due to murine models. So phase 1 is going to take place from the first day to the 7th day after viral encounter with the host. It's going to be characterized by a viral entry and activation of the innate immune response. So the virus comes in through endocytosis. This is the cardiac myocyte. And if the innate immune response is triggered, then we're going to have apoptosis, we're going to have injury, we're going to have necrosis. We have an active viral replication as well. And that's going to lead us to phase 2. Phase 2 is going to start from week 1 to week 4 after viral contact with the host. And it's characterized by the activation of the acquired immune response. So the innate immune response is not only going to be acting, but the acquired immune response is going to be like damaging some cells as well. So we have infiltration of T cells over here. We have cardiac autoantibodies as well. And phase 3 has two different roads. The first road would be a recovery. So the body is able, and the supportive medication and all the supportive care we give the patient is going to enable the recovery of that myocarditis. So we don't have any sequelae and the patient returns to normal activity. Or we have the second road, which is disease progression. So myocardial damage may persist, then comes fibrosis, increased cardiac mass, and we may now talk about chronic dilated cardiomyopathy. This is also a schema I liked because it showed the different cells that were involved regarding the innate immune response and the adaptive immune response as well. So we have different clinical manifestations, right? We typically have a history of a child who comes into the ER complaining and having a history of viral prodrome and non-specific symptoms 2 weeks prior to the presentation. So you may have presented with nausea, abdominal pain, fever, or an infant's unexplained irritability. And we may see the patient in that moment with signs and symptoms of heart failure. So chest pain, palpitations, exercise intolerance, dyspnea, tachypnea, or even syncope. During the physical examination, in the respiratory system, we may note that the patient has tachypnea, retractions or rales. The cardiovascular symptom, we might listen to a S3 or S4 sound, a mitral or tricuspid murmur that wasn't there before. In the gastrointestinal system, we may have an enlarged liver. We may have a low urine output or edema regarding the renal system, and just signs of low cardiac output. So a child who has shock, well, of course, depending on the type of shock that he has, the almost most common presentation of a shock in children is a prolonged capillary refill time. So we just note that the patient has about 3-4 seconds of capillary refill time. His extremities can be cold, even a little purple. If the shock persists and we don't note it, or if the parents don't come in at the right time, that patient may present with hypotension or even an altered mental status. So we know that most of the algorithms we have and the studies we have come from adults, right? So it's really not very proper to evaluate children. It's bioethically not very easy either. So back in 1997, Dr. Russell Hirsch and his group wanted to see if all those things we heard about adults, about cardiac troponin I, were also available for children. So what he did, he divided his patients into 3 groups. He had 120 patients in the outpatient setting. He had 96 patients in the congenital stable cardiomyopathy group, and he had 59 critical patients. And he concluded with his group that the normal values for cardiac troponin I was less than 2 nanograms per deciliter. He also concluded that the higher troponin value that a child had, the worst outcome. Most of them passed away. So he also concluded that the troponin, the cardiac troponin I, did have a potential use in cardiac injury. Later on, about 2 decades later, Dr. Casselli obtained blood samples from about 357 healthy pediatric patients. The CTNI plasma levels were measured, and he found that during the first month of life, the cardiac TNI level was higher. And remember, I talked about the structural a change that takes place about 20 days after a baby is born, I think it would be related to that. He started saying, oh, okay, so kids, I mean, we can take cardiac troponin I, it's useful in a cardiac situation, but they also need different cutoff values from adults. He also posed the importance of suggesting in further studies the need for specific cutoff values in age and sex. So this study really showed us, okay, we do have cutoff values. Infants are a completely different scenario. Neonates are a completely different scenario, but we still need to keep on studying and seeing what are those cutoff values. This is an article that was published in Circulation just in April. It is measuring 4 different types of essay. Let's remember the essays, the reference values for the essays are used for adults. And let's remember, children are not small adults. So what they wanted to see is that if the level of the reference level, the upper reference limit of the essays they had that they used for adults could be used as well in kids, like in different ages. And what they really found out is that the 99th percentile of the URL is way higher in adults than it is in children. So we have another article that really is supporting that theory we have. Kids need lower cutoff values. So, okay, we know that using the 99th percentile, we have different cutoff values. But then what they also saw in this study was that if we really use the 97.5th percentile, we could have a difference between sex and age. So it's different to have a 14-year-old boy having acute chest pain and palpitations than a 4-year-old boy. But that is only if we use the 97.5th percentile. That's due to the statistical analysis that's done after the test is made. Okay, so this article opens our eyes way more. Andres talked about the 99th percentile and what the algorithm is for the 99th percentile. We now know in kids we cannot use the 99th percentile. We need to use the 97.5th percentile according to the essay used. And that is going to give us really, really more specific reference values. And this is just a little chart of how the statistical analysis was made and how they used the 97.5th percentile. So we have another article regarding that theory we had. And this article carried out by Dr. Dion's group, she used 1,993 patients, 1,993 patients aged 0 to 21 from January 2005 to December 2018, in whom at least one troponin I level was obtained during the outpatient setting in Boston Children's Hospital or the inpatient setting without a history of cardiovascular disease. And what she concluded was that the positive predictive value of an elevated troponin for a cardiac diagnosis was 85% for patients with a cardiac presentation. That means the kid comes into the ER, he has a chest pain, he has palpitations, he has an EKG that has sinus tachycardia. For that patient, it is 85% likely that he's going to have something cardiovascular. In this specific webinar, acute myocarditis. And the negative predictive value of a non-elevated troponin was 89% for the entire group and 96% of those without a cardiac presentation. That means we really need to use tests that are going to guide our diagnosis. If we're not sure if the kid has something that's pulmonary, that's respiratory, or cardiovascular, maybe we need to dig into the history a little bit more, the previous medical and history and all that. But if we have cardiovascular suspicion, I have a diagnosis that I think that child has something cardiovascular, you can take the Troponin I, and it's going to help you a lot. So that's like uniting the puzzle pieces together. How is the diagnosis of an acute myocarditis made? Cooper in 2012 really proposed this three-tier step for diagnosing acute myocarditis. So we have the first scenario. We have a possible subclinical acute myocarditis. What does that mean? We have a patient without cardiovascular symptoms, but what do we need to make? And the history that we really don't know what the diagnosis is. We need to take a cardiac biomarker. We need to take a cardiac biomarker. Okay? If what I'm thinking is not that clear, if I'm confused with the diagnosis, we need to start with a cardiac biomarker. Of course, we can, again, just take an EKG or an echocardiogram. We can do that. Notice that here in number 3, he says, we can also have the diagnosis of a possible subclinical acute myocarditis if there is an abnormal cardiac function on an echocardiogram or a cardiac MRI. I'm just going to pause there for just a second. I come from a low to middle income country. We do not have a lot of tests that may be available in other places of the world. So, like I mentioned, if you are going to take or ask for a test, it has to be just guided. You have to know where you're going. We don't have cardiac MRI available in most hospitals I've worked at because you need an anesthesiologist, and he may have to be a pediatric anesthesiologist. We really don't have those where I come from, and it's really sad to say, but we have to use what we have. So if you have a cardiac biomarker, which is a test that is super readily available in every hospital, an EKG echocardiogram, you can diagnose acute myocarditis without a doubt. Okay. The second tier step for diagnosing acute myocarditis would be a probable acute myocarditis, which is the same as we saw in the previous numbers, but that patient does have cardiovascular symptoms. And notice what he says. He says, please, biomarkers, cardiac biomarkers are needed. In this case, was a cardiac TNI. And lastly, we have the definite myocarditis. What is the diagnosis? How is it made? It's a biopsy. It's a cardiac biopsy. So imagine if we don't even have, or if in your hospitals you don't have a cardiac MRI, how are you going to get a cardiac biopsy? That's going to pose just some issues. So again, use what you have and be resourceful again with the tests you asked for. What is the management of acute myocarditis? It really depends. It really depends on the severity. We always start with the pediatric advanced life support pathway, the ABC. We may need to use the ICU. We have antiarrhythmic drugs, electrical conversion, transvenous pacing, inotropic agents, diuretics or afterload reducing agents, beta blockers, aldosterone antagonists. We almost always use IVIG, glucocorticoids as well to stabilize that innate immune response. And in some cases, we need to use ECMO as well. And unfortunately, in a small percentage of cases, we do need to have heart transplantation as well. The outcome in most kids recover in like about 3 to 4 weeks, 2 to 4 weeks. But we do have also predictors of poor outcome. We have elevated cardiac biomarkers in the presentation, we know that that patient is going to have a poorer outcome because of a longer length of stay, because that patient would need most likely ECMO, and those patients have a higher mortality. If you have tachyarrhythmias during the presentation, or an NYHA class for dyspnea or ventricular dysfunction, those patients really have poorer outcome. And remember the pathophysiology, the 3 phases. Well, those patients go into the second route of the pathophysiology, phase 3, having cardiac fibrosis and chronic dilated cardiomyopathy. Really, some conclusions to this webinar. Learning and remember the physiology of TNI can really help recall in what clinical scenarios it can be used, not only in adults in acute myocardial infarction. We saw today that in acute myocarditis, we can also use it, and it's readily available. TNI is widely used in both pediatric and adult patients. What are we missing? We are missing reference values for infants, and that is going to pose just complications in the future. But again, that's like a call to unite in investigation. We need to have those cutoff values for little kids, for infants less than 1 year of age. And high sensitivity troponin I in pediatric is not superior to cardiac troponin I in the clinical diagnosis of myocarditis. We do need that comparison between high sensitivity and cardiac troponin I. We need to have a reference group, and we need to study if we can conclude the same thing that Andres concluded with his adult patients. Thank you very much.
Thank you, Dr. Andreas and Dr. Lizeth. Indeed, it was a very insightful webinar on the use of troponin in pediatric and adult patients. Unfortunately, we don't have much time for the Q&A session. We have noted down all the questions and will be responding to you via email. This webinar will be available on our YouTube channel for further viewing. And in case if you have any questions, feel free to reach out to us. Again, I want to thank you all who have joined from across the globe for attending this webinar.